Thank you for inviting me to be part of this very prestigious and famous Congress. In Sydney, we have a very strong relationship with Leon from the time that I first met Philippe about 16, 17 years ago when he visited London, Ontario. I was doing my fellowship, and since that time, we've had many French fellows and visitors come through, many of whom are here today, and all of whom have become very good friends. So it's wonderful to be here and share this meeting with you. These are my disclosures. So I've been asked to share the Australian experience, and particularly the epidemiology, the etiology revision within Australia. And we're fortunate in Australia that we have the Australian Joint Replacement Registry, which I think probably most people will be familiar with because it's become quite well known and quoted around the world. It was established in 1999 and became fully operational in 2002. And every year we get one of these booklets, which is a big document now on our desks, in about 2 weeks' time. So what I'm going to present today is the summary from last year's report, which takes us up to the end of 2016. So as of December 2016, there were over 650,000 knee procedures in the registry. Almost 550,000 were primary knee replacements, and more than 52,000 done in 2016. And this number increases every year. So there was increased use of unis, but still not that many as a percentage of the whole. About 50,000 are in the registry, but I won't talk about unis today because that wasn't part of the brief. And we have some new data on medial pivots and also highly cross-linked polyethylene. So for those who aren't familiar, I don't think there is a national registry in France. So whenever we do a joint replacement in Australia, we have these forms to fill out, which has information about the patient, information about the implants, and then if it's a revision, we can put down the cause of the revision. So these are the common ones that we can tick a box, or we can list anything in addition to that. So this is a registry. We're not talking about outcomes or how well the patient is doing functionally. This is endpoint where revision requiring a new implant. This year they're starting collecting PROMs as a pilot study, and that is planned to expand across the entire Australian population. Another function that we have is we can look personally at our own revision rate, so we can compare that to the national average, as you see here. So we can only do that. Nobody else can do that at this stage. There obviously is concerns that maybe government one day will want to look at that, but currently this is just for ourselves to look at our own revision rate. So the 2017 report, this is the overall revision rate over 16 years in Australia, 8% total revision rate, which is, we think, is pretty good overall. That's all implants. And you can see the list here, and it's sort of similar to the list that we just saw in the previous talk. Loosening and infection are the two most common, followed by a number of other reasons: pain, instability, patellar erosion, arthropfibrosis, which I think we could say is stiffness, fracture, malalignment, lysis, wear of the tibial insert, metal-related pathology, incorrect sizing, and others. So these are what people put down on the form, so there's obviously some overlap between these categories. And when we have such a big registry, we don't get quite the same level of detail that you will in the registry and report that we had in the last talk. So this is the cumulative incidence, and you can see the causes of revision here. The red line is infection and green is loosening. So in the first 3 years, infection is the most common reason. Between 3 and 5 years, it's similar to loosening. Infection tends to level off but gradually increase, but loosening keeps going up steadily. And below that are patellofemoral pain, and instability as other causes. The types of revisions that are done, about a quarter are revised to a full knee replacement, so a full revision. 20% are just the insert, and then we have ones where just the patella is resurfaced, others where the insert is replaced with the patella resurfacing, probably when it's being done down the track and people take the opportunity to replace the insert, and then a number of other individual component revisions, as you see there. So with the registry, we can look at comparisons of different implants, different techniques, and look at the variation that gives us in the revision rate. So I'm going to give you a few examples of this that we've looked at with the registry over the last 12 months. So cemented versus cementless fixation. In Australia, about 2/3 of implants are cemented, and then the others are hybrid, which is a cemented tibia, cementless femur, and then fully cementless. So that's the distribution currently within Australia. And if we look at the revision rate, there's a significantly increased revision rate in cruciate retaining knees if they're cementless. So because the numbers are so big in the registry, if you see any separation of these lines, it's almost always a significant difference. And then if we look at posterior stabilised, The hybrid ones, so with a cementless femoral component, as well as the cementless, have a higher revision rate. So that would suggest to us that if we're doing posterior stabilised, it would be a good idea to cement them if you want to have a low revision rate. If you look at patellar resurfacing, you can see now that more than half of knees in Australia have the patella resurfaced, and that changed in about 2010 when it crossed over to about 64% have primary patella resurfacing now. And not surprisingly, if you resurface the patella, your revision rate is lower. So that is that's probably my main reason for resurfacing the patella in the majority of cases. I know it's going to reduce the revision rate for my patients. If we look at comparisons with different types of implant, posterior stabilised, cruciate retaining and medial pivot, this is the distribution. So about 2/3 in Australia are cruciate retaining, about 25% to 30% are PS, and medial pivot is gradually starting to increase over the last few years in Australia. And if we look at the revision rate, the lowest revision rate is for cruciate retaining implants. Posterior stabilised and medial pivot are higher, significantly higher. If we then break that down to PS and CR that have had the patella replaced or not replaced, a much, much higher revision rate is for the posterior stabilised without a patella. So this is useful information for people doing posterior stabilised, that if you want to reduce your revision, you really should resurface the patella, whereas if you don't like to resurface the patella, it's probably safer to use a cruciate retaining implant. And the same goes for the medial pivot. If you don't resurface the patella in the medial pivot, then you'll get a much higher revision rate. If you do, it's much lower. And this is obviously specific to the small number of medial pivot designs within Australia. We can look at the polyethylene type. So cross-linked polyethylene, highly cross-linked polyethylene, has become the more common one used in Australia a few years ago, so it's now about 50% of all implants. And there is a significant difference. If you use highly cross-linked polyethylene, the revision rate is significantly lower, and you can see those two lines are moving further and further apart as time goes by, so that seems to reduce the revision rate as well. And if we look at the reasons for revision, it's mostly infection and loosening, so that's not surprising, things that will relate to polyethylene wear. I'll talk a bit more about that later. We've also had a recent introduction of highly cross-linked with antioxidant. This does not seem to improve the revision rate above just the highly cross-linked. Computer navigation is quite popular in Australia. It's gradually increasing. You see that green line, it's gradually increasing. It's just over 30% now. And we're seeing a difference in the outcome, in the revision rate, particularly in younger patients. So the blue and the red line there are patients over the age of 65. It doesn't seem to make any difference there. Over the age of 65, you have a lower revision rate. So the more active patients, the ones who are more likely to wear their implants out. If we look at infection and whether the type of polyethylene we use has an impact on that, this is a study that was done and published fairly recently, looking at whether the different bearing surfaces that we use actually impact on the risk of revision for infection. So this study is over about 16 years from data from the registry. This one just looked at cruciate retaining. So MS means minimally stabilised, which effectively is cruciate retaining implants. And for this first study, it excluded PS and also fully stabilised or hinge knees. And it didn't take into account patella resurfacing or fixation. And they took out the first 6 months to get rid of what they thought were probably acute primary infections not related to the implants. And to investigate the cross-linking effect, they compared chrome cobalt with cross-linked poly to non-cross-linked poly. They also did a sub-study to see whether oxinium had any effect on either the cross-linked polys or the non-cross-linked polys. So this was, after exclusions, 326,000 knee replacements, 1,500 revision were revised for infection. And as you can see here, I'll go through quite a few graphs, but the basic message is that the highly cross-linked polyethylenes had a lower rate of revision than the standard non-cross-linked polyethylene. And that was whether it was with chrome cobalt or with oxinium. That's the overall group. This is if we look at the males. So if you look at males, patients who on our registry have a higher revision rate, this effect seems to be more of an issue for the males than it is for the females. And then if we drill down to younger males, the ones who have a much higher revision rate, once again, the effect is much higher in those who have a non-highly cross-linked polyethylene. The same pattern is there for the females, but not the same revision rate. And if we look at the females, once again, it seems to be not as big an effect as in the males, but more so if they're young and presumably more active. So the findings of this was that there's a 26% reduction if people had highly cross-linked polyethylene compared to non-cross-linked polyethylene. The oxinium didn't seem to make any added benefit to that, And this has been published showing that 26% revision rate. And this is another study that is about to be published. And once again, this one looks at posterior stabilised implants compared to cruciate retaining. And the effects are still there that highly cross-linked polyethylene has a much lower rate of infection, but it's even more so if you use posterior stabilised. Without that, you will get a much higher rate of infection. So this is thought to be that with the posterior stabilised implant, with a non-cross-linked polyethylene, you get a higher polyethylene wear, and we think that the polyethylene particles will have an effect on the immune system and promote infection. This seems to be borne out in this. So in summary, 18 years on, there are 650,000 knee replacements within the registry. The major reasons for revision in this population are loosening, infection, pain and instability. And it's been a very useful tool for us in Australia because having such large numbers allows us to link surgical techniques like computer navigation and the cementing versus cementless and implant types to their outcomes. And that over the last 18 years has allowed us to identify problems, change our practice and hopefully improve our outcomes. I'd like to thank all the people at the registry who helped put this data together, and thanks for your attention.